Hello, everyone. Welcome to our monthly ASC e-journal presentation. I'm Sukriti Baskota. I'm currently an assistant professor at Columbia University Medical Center. I'm also the vice chair of ASC e-journal committee. Today, it is my pleasure to welcome Dr. Dina Zenezan. She is a PZY 2 currently at Temple University, and she is very much interested in pursuing cytopathology fellowship. The title of her journal talk today is Chordoma, Analysis of 47 FNA in Cytologic Imprint and Small Biopsy Specimens. If you have any questions throughout her talk, please feel free to put your questions in the chat box and we will get to it at the end of the presentation. Dina, take it over.
All right, thank you so much, Dr. Baskota, for this introduction. So hello, everybody, and it's my pleasure actually today to be presenting this beautiful article for the AEC Journal webinar. Again, my article is about chordoma, which is analysis of 47 fine needle aspiration biopsy, cytologic imprint, and small biopsy specimen. So these articles are actually presented on September 2022 by the authors Dr. Wackley, Dr. Saoud, and Dr. Ali. And I have no conflict of interest, although I appreciate the authors very much. And actually, today we have one of the authors, Dr. Carla Saoud. She is actually direct fellow in the cytopathology fellow at Johns Hopkins, and she is actually also finished her residency training back in Johns Hopkins after doing 2 years of anatomic pathology residency back in her home country in Lebanon. So this is me. I'm a second-year pathology resident at Temple University Hospital in Philadelphia in Pennsylvania. And this is our author, Dr. Carla Saoud. So as we started per the article, so we need to know what are the learning objectives that we might get from this beautiful article. So the first one is to describe the cytomorphologic features of chordoma. And the second is to evaluate basically the utility of various cytologic FNA preparation for diagnosing chordoma, and to assess the accuracy of FNA in diagnosing chordoma compared to surgical specimens, to also determine the FNA's ability to differentiate between different types of chordoma, and last, to discuss the challenges associated with sampling in chordoma diagnosis using FNA-guided biopsy. Starting for introduction, so as we all know that chordoma is kind of rare tumor, malignant tumor that's basically originating from the notochordal remnants, and its occurrence is very low and has kind of low incidence, and it's usually more common in males compared to females. For age, it's usually predominantly appears in adults, and it's very less common to be presented in children. However, we can still have some cases there. And for location, it usually arises in the axial skeleton or like around the axial area. Rarely, excuse me, rarely it can arise outside the axial area. So mostly it arises in the skull base, the mobile spines, and the sacrococcygeal area. So chordoma has different types and a different morphologic presentation. So for the first part is the conventional chordoma. So chordoma basically, as we can see here, it can produce like this kind of eosinophilic cells that are associated with, like as we can see here, there is a central fiber septa that can separating the cells here into kind of lobules. So we have this kind of lobular architecture, and together with the presence of some kind of myxoid material that we can basically appreciate in this kind of chordomas. And some kind of cells, it's called fossiliferous cells, they acquire more kind of cytoplasm. So they started to be more foamy, which we can also barely see in here in some areas. For staining, we have a brachyury stain. So the brachyury stain is basically a nuclear stain, which is basically a nuclear transcription factor that basically can expressed in any kind of tumors that have notochordal cell origin. Brachyury is not 100% specific, but in most cases, they are very efficient in diagnosing chordoma. And we have also to keep in mind that sometimes brachyury can be affected through the decalcification procedure. So sometimes if we have chordoma and we do decalcification of the bone, and then we do stains of brachyury, sometimes we might not stain, it might not get the stain well. Although conventional chordoma itself can have the same picture as we mentioned last picture, but at the same time, chordoma may have some different presentation. Conventional chordoma can have different presentation. Sometimes it has this kind of spindly morphology in which we have some fascicles and some kind of wavy, or not wavy, but like spindle-shaped cells. In other situations, it can be presented with acquiring more cytoplasm, basically, and try to have like this kind of bone formation here and there, which can be easily mistaken for benign notochordal tumor. And the last thing is that it may have more abundant cytoplasm, and it's gonna have kind of rhabdoid appearance. As we can see here, this beautiful pseudo-inclusion, eosinophilic pseudo-inclusion here and there can basically push the nucleus to one side and give the conventional chordoma this kind of beautiful rhabdoid morphology. The second actually type of chordoma is a dedifferentiated chordoma. So sometimes it's hard to diagnose dedifferentiated chordoma when it is solely presented as dedifferentiated chordoma, like when we can only see the dedifferentiated part. But luckily, sometimes we can see the dedifferentiated part together with the differentiated part. As we can see here in this picture, on the right side, we can appreciate the conventional type chordoma that was like very obvious. And on the left side and the upper part of the slide, we can appreciate this kind of ugly looking, very bad dedifferentiated part of the chordoma. And basically, dedifferentiated chordoma is usually associated with very bad prognosis. The third one is a poorly differentiated chordoma. So as we can see here, the poorly differentiated chordoma can basically presented with sheets of cells that most likely lacks the chondromyxoid or the myxoid matrix that presents in the conventional chordoma. And if we go higher power, we can appreciate the very bad looking appearance, the great cytomorphologic variation, and also the prominent nucleoli appearance in our picture. So back to our study. So at the method for the study, we basically have the database. Our database for this beautiful article was that the specimen actually that's diagnosed as chordoma or possible chordoma. And we also have the surgical pathology database that's examined for cases of chordoma with corresponding cytologic specimens. So the patient demographics, clinical presentation, and cytopathologic diagnosis were recorded. Luckily, all the cases had confirmatory histopathologic diagnosis after surgical resection, which is basically in this article as an inclusion criteria. So from what I heard or what I understand of this article is that every case should have, after resection, should have diagnosis for chordoma to confirm that this case was chordoma. Specimens should include, specimens also included FNA biopsy with or without corresponding core needle biopsies. So this beautiful article is about like two combination from two different experiences or institutions. So from Ohio State University, the FNA was basically done on the palpable masses, while at Johns Hopkins, all of the FNA were basically image guided. So they did like 3 to 4 passes per each case, which was rinsed in RPMI, immediate microscopic assessment after staining with Romanowski stain or R stain, basically done for this kind of cases. And sometimes they have also additional pap smears in most of the cases, and whenever they have a pap smear and there's an availability for having extra material for cell block, like basically formalin-fixed cell block, they were also performing cell block on the pap smears. And the IHC actually was done on the cell blocks. So, and whenever they have concurrent needle biopsy with FNA biopsy in a subset of cases, that was from Johns Hopkins Hospital. And as a result, so for the results, like 47 cases of chordoma was retrieved from around 44 patients. And the age range actually was from 5 to 81 years, and the main age was around 55 years. 27 cases was primary, 10 was locally recurrent chordoma, and 7 was actually metastatic tumors. So 2 aspirates actually were from the appendicular skeleton, 2 from the trunk, 1 from the lymph node, and it's most likely MITS, and 42 cases was from, as we said, the most common axial and periaxial skeleton and surrounding soft tissues. 4 were cytological touch imprints, while the remainder, or most of them, were basically FNA biopsy specimens. And let's go for the diagnosis itself. So they basically kind of categorize the diagnosis to chordoma or consistent with chordoma. Second one, suspicious for chordoma. Third one, malignant neoplasm. So basically the cases that they will be able to identify as chordoma, they call it chordoma or consistent with chordoma, which was like 44 cases of a total number of cases that they have. The second one is the suspicious for chordoma, and was 2 cases, and those 2 cases was confirmed to be chordoma by the surgical resection. And the third one was malignant neoplasm. So I guess this one they wasn't be able to identify further whether this is chordoma or not chordoma, so they just basically keep it as malignant neoplasm. And the third one, there was actually single case of benign notochordal tumor that was misdiagnosed as chordoma. And a single case also was poorly differentiated chordoma, while the remaining of the cases was actually conventional type of chordoma. So again, based on these kind of like results, so the study diagnostic accuracy was actually 21, and the concurrent tissue biopsy was performed in 51% of the cases. IHC stain was done in 29 cases, which basically represent 62% of the cases. So they will be able to do procure stain in 23 or of 24 cases, basically in this study. And again, this article contains very nice pictures regarding the cytomorphologic characterization for chordoma. So as we can see here, this is a conventional type of chordoma, in which on the left side, we can see there are multiple single scattered cells that's kind of monotonous, and this kind of cells is kind of obscured by the presence of this kind of beautiful magenta colored myxoid material. And on the right side, we can see this is a pap smear. On the right side, we can see that we can have like more pale background, like more compared to what we see here in the R stain on the left side. And this also beautiful pap smear that can, as we can see here, most of the cytology is based on like imagination. So we can see here that this is kind of lobulated architecture that's forming here and there from the kind of cells. They are forming this kind of groups that's kind of lobulated. And we can see also like kind of like sheets, also the cells, and the cells is forming this kind of clusters. And there is a little bit of the myxoid or myxoid background, but as we know that pap smear is mostly about the cellular morphology itself, while the R stain is mostly the background. And here we can see on the left side, we can see mostly the kind of forming the cells itself. It's kind of tried to be like more mononucleated, some are multinucleated, and some are also binucleated. And on the right side, we can see here these kinds of different sheets again of single cells, that's kind of monotonous. And they also have kind of conventional type chordoma. They have this kind of myxoid material, and they also don't have any necrosis. They don't have any background inflammation as well. And this is actually the single poorly differentiated chordoma case that this article will be able to identify. And as I mentioned before, only one case was diagnosed as poorly differentiated chordoma, while the other cases of chordoma was kind of conventional type chordoma. So as we can see here in the left side, we see those kind of cells that are, again, sheets of cells that are singly or kind of not very clustery arranged. They are kind of single cell, and we can appreciate here that we don't have any kind of myxoid or matrix that's usually actually stick with the morphology of poorly differentiated chordoma itself. So as I mentioned before, the poorly differentiated chordoma rarely have this kind of myxoid background or this myxoid material that presents with the conventional chordoma. So mostly sheets of cells that are very bad looking, very ugly looking. And if we can go to the right side of slides here, we can see that this is basically on the right side, we can see the R stain that basically show the cells that are, again, on higher power. It's ugly looking, and it has this kind of like more kind of moderate amount of cytoplasm, but it has also some kind of variation, not very frequent, but still have variation on the morphologic features and also in the nuclear polymorphism. And this is actually the cell block that was done on the cases. So this is what actually one of the chordoma cases that have actually a cell block. So on the right side, that we can easily appreciate the conventional type of chordoma, again with this kind of lobulated cells that have this eosinophilic cytoplasm. And we can also appreciate here some of myxoid material that present on the left side, while on the other side of the same, in the same block, we can easily, on the right side, basically this is the brachyury stain of the same section of the cell block that can show like kind of diffuse or kind of positivity for the brachyury stain. So as per conclusion, we can say that in this article, basically 91 cases or 91% overall accuracy confirm the chordoma is identifiable through FNA. And because the resection itself with negative margins is the preferred treatment, so the small biopsy samples such as FNA provide diagnostic role in the treatment of decision. And the treatment decision basically. And with this FNA of every soft tissue or bone neoplasm, obtaining additional kind of materials like for the cell block, like for example, if I have like an FNA and I have a concurrent biopsy, but at the same time I have a cell block, so that's basically allow me to have extra additional like tissue for additional ancillary studies if I want, or additional molecular studies if we prefer. So I think it's really enhance the diagnostic precision as total. And also the FNA and small tissue biopsy specimen shows a very high degree of diagnostic accuracy in the recognition of chordoma. So this is basically the conclusion of this article. And so I'm going to ask our author, Carla, the questions about this article. Carla, are you with me?
Yes.
Okay. All right. So the first question is that whether we have whether there's any cases, Carla, that you don't have in which you doesn't have any either core biopsy or either cell block to do, ancillary studies regarding the brachyury. And if there was something like this, so how was the approach toward this kind of a specimen, especially regarding the diagnosis of chordoma?
Yeah, so in our series at Johns Hopkins, we had one case without cell block or core needle biopsy, and I think there are few cases, 2 or 3 from the Ohio State University. We can call them on cytology alone without like brachyury in the appropriate clinical setting, meaning like a tumor mass-forming lesion, destructive lesion in the clivus or in the sacrum, and with the appropriate cytomorphologic features of like these epithelioid cells, a background of a magenta colored matrix, or on pap smear, this like acellular matrix. So we could call it, and we called it on several cases as chordoma or consistent with chordoma in the appropriate clinical setting.
All right. Okay. So
sorry to interrupt, Dina. I have a quick follow-up question to Dr. Saoud on that. So did you have a history on those cases of a prior chordoma, or was it a first-time diagnosis?
For ours from Johns Hopkins, we had the first-time diagnosis, but we had the imaging.
Okay, thank you.
all right. So my next question is that, so how many non-diagnostic cases that you have in this, like in this study, and if there's any non-diagnostic, so what's basically the main thing or that you faced or regarding the sampling at like as a whole?
Yeah.
So that makes this kind of challenging.
The cases that we involved in the study were all diagnostic on cytology. We did not have non-diagnostic. Some were described like malignant neoplasm, and were found to have like core needle, or like after they have been like found on surgical pathology resection that they are chordoma, but we did not have non-diagnostic at all. And we did have 3 non-diagnostic core biopsies, but those had a diagnostic FNA or like FNA/core needle biopsy. And on the other hand, we had 2 cases of suspicious for chordoma, but had diagnostic core needle biopsy. But FNA alone, we did not have non-diagnostic.
All right. Okay. Thank you very much. And one more question is, whether there's any molecular studies that's done for those cases?
When I collected the data, I did not have any except for the fully differentiated chordoma. They did the SNP microarrays, and they did not find any copy. Yeah, they did not no significant copy number changes or loss of heterozygosity in this specimen, but they did not do NGS, and I checked today, and they did not do on this one.
All right. Okay. Well, thank you very much for your like your time, and thank you very much for agreeing to join us for this webinar.
Sure, no problem.
If there is anybody has any questions?
Yes, we do have some questions in the chat box. The first one is, would a dedifferentiated or poorly differentiated chordoma still be positive for brachyury? What was your experience in this study, Dr. Saoud?
Poorly differentiated, so the DDIF usually have weaker. Sometimes they are negative. Ours, we did not have the differentiated, but we had the poorly diff. Our poorly diff was positive, but in general, dedifferentiated chordomas usually lose their brachyury, but they can have weak or sometimes keep it. A poorly differentiated might have it, but in general, they might lose it.
I see. Thank you for answering that. The next questions we have is, were the authors able to demonstrate if there is any non-inferiority or superiority between FNA versus core needle biopsies?
Superiority of core versus
FNA?
We did not especially work on core needle biopsy versus the FNA, but from our experience, the FNA was highly accurate. So we were able to diagnose on FNA alone, 91% accuracy. So I find it's very accurate even without the biopsy, and especially that we did not have non-diagnostic FNA, but we had 3 non-diagnostic biopsy.
And I just want to add something that like to me, FNA is a cheap method. Like it's non-invasive procedure, and as we did and I think per the article, the Ohio State, they basically do the FNA on palpable methods, so on palpable masses, which is, I think FNA, it's if it was able to produce the diagnosis, and it's kind of technically non-invasive procedure, so why not?
I totally agree for that, and I'm pretty sure all the cytopathologists in this panel agrees to that as well. I have a third question as well. What differential would you consider if histologically similar to a conventional chordoma that would warrant immunohistochemistry, or are most of these histologically conventional chordoma, I would imagine, mainly diagnosed through histomorphology?
So what is the cytomorphologic differential diagnosis of chordoma?
Yeah.
I would maybe.
I think I have some in my mind for now. So
Sorry.
yeah, so like I think for conventional chordoma, it can basically look like a lot of differential diagnosis. Like it has a lot of differential diagnosis. One of them is like as far as I know, is like it could be like kind of metastatic adenocarcinoma. This is one of the differentials, and sometimes when it's very ugly, it can be look like, for example, like the differentiated chordoma can look like anything basically. Like it can look like the differentiated any kind of sarcoma. And also per the article as well, if you have like a very kind of classic looking conventional chordoma with some kind of bone formation, this can be mistaken as a benign entity of like the notochordal tumor, which is a benign notochordal tumor. So I think it has this, with this myxoid kind of myxoid material, there is a lot of differential diagnosis, and I don't know if like for sure Carla, she has more to add, more than me.
I can add, like, just because of the cytokeratin positivity, you can somebody can call it like metastatic carcinoma or adenocarcinoma, and the brachyury would help in this setting. Myoepithelial tumors, myoepithelial carcinoma, especially with the expression of cytokeratin, can be involved, but taken like the radiologic correlation, you can just like favor the diagnosis of chordoma. You can also have extraskeletal chondrosarcoma, which is can occur there, but also will have a negative cytokeratin and will have a rearrangement of NR4A3. Other hemangioblastoma maybe. This is what the melanoma, if you don't have a cell block and you have this epithelioid cell, one can think about it as well. So I think these are the main differential diagnoses. And chondrosarcoma for sure, sorry.
Right, those are great differentials, and we should also keep in mind of the sampling variability. Many of the times we might not get the matrix material essential for the diagnosis, and in those cases also, whenever we have a good yield in the cell block or even core needle biopsy, it might be helpful. We do not have any more questions. This was a great presentation. Thank you for accepting our invitation and being here, Dr. Saoud. Thank you, Dina, for accepting our invite in such a short notice and doing an excellent job. Twitter chat yesterday night was also looked like a great fun. I'm sorry I missed majority of it, but I did follow it up a bit. Thank you everyone for attending. We look forward to another month of Journal Club next month, and we see you in July. Have a great summer.
Thank you so much.
Thank you so much.
You too.